we'll pass on to next speaker, Dr. Anil, I think. Dr. Anil Radhakrishnan. Is there, no? Huh, I can tell. He'll be talking about the penetrating keratoplasty, the key points.
If you look at the corneal transplant or program all around the world, I think there is a general trend towards more of lamellar procedures. And this is one representative Western data, which tells you that about 57, close to 60% of people have endothelial pathology, and endothelial replacement is the thing to do. But is penetrating keratoplasty really fighting for space? If you look at the data from India, that is a more recent data, that is a very good data by Dr. Namrata Sharma, looking at the 10 eye banks, we see that infections and corneal scars still remain the major indications for corneal transplant. If you look at the chart there, I think 35% is because of infections. So in a country like India, keratoplasty, penetrating keratoplasty is still very relevant. Almost 80% of the surgical work that we do was for penetrating keratoplasty. And it's 12.4. Previously, it was close to 1%. Now it is about 12.4%. All this DSEC, DMEC, and all that is there, but it is much less in comparison to penetrating keratoplasty. Whichever transplant you do, it's very, very important to have a very good preoperative evaluation. We should assess whether the visual acuity is really corresponding to the corneal pathology. If you have a corneal pathology, then you'll have good results. So look at the tropias. If it is a tropia, it tells you that the visual deprivation has been for a long period of time. Then lag ophthalmos should really be looked into. So even if you do the best surgery possible, if you have lag ophthalmos, the graft is bound to fail. So lag ophthalmos, lid pathology, dry eye, all these things should be corrected. And if there is a severe dry eye, it's better not to do a keratoplasty because the graft is not going to survive. Same thing with neurotrophic keratitis and limbal stem cell deficiency. Unless you address it and then only you think of a transplant. Otherwise, it is bound to fail. So preoperative evaluation is most crucial in keratoplasty. As I was mentioning, a thorough slit lamp examination. Special attention should be paid to the vascularization, especially the deep vascularization. If you have more than one quadrant of deep vascularization, the chance of graft failure is much, much more. The inflammatory status, if you have HSV keratitis and if the eye is slightly inflamed and then you're doing a transplant, the results are bound to be much, much worse compared to a silent eye. Again, as I mentioned before, ocular surface should be given proper care. So, slit lamp examination, pupils, lens, then IOP should be well evaluated. And if the IOP is seen to be high, you have to address the glaucoma and then do a transplant 3 months after the procedure. Indirect ophthalmoscopy or B scan should be done to make sure that there is no other coexistent retinal pathology. So I'm not going to the details, but there are outcomes really depend on the disease process that you have. If you have a keratoconus or an isolated central scar, the results are excellent. While if you have something like chemical burns and mild, even moderate dry eye, the results are going to be bad. And if you have neurotrophism, it is better not to touch that patient. So in the procedure, we generally put rectus sutures, and if you have a pediatric keratoplasty or if there is a aphakic status in which the ciliary rigidity is less and the vitreous is likely to come into the anterior chamber, it's better to put a flaring gas ring. The sizing of the trephine will depend on the pathology, First is the corneal size. If it's a larger cornea, you go for a larger graft. It mostly depends on the pathology. If it's a central corneal scar, you tend to make the trephination as small as possible. The larger the trephine you do, the larger graft you take, you can have more chance of rejection. And sometimes the pathology may be eccentric, and eccentric pathology, again, the chance of rejection is more because you'll be more closer to the limbus and closer to the immune status, and the chance of immunological events will be much, much more. Donor trephination is usually done from the endothelial side. Usually about 0.5 mm oversized graft is that we used. For keratoconus, especially myopic keratoconus, you can use same size graft. And suction trephines are used, like Barron's trephine is there, which can actually give make sure that the tissue does not move while you do the trephination. So you first you inflate the anterior chamber with viscoelastic, make a cut in one area, entry. Then with trephine, you cut from both the areas. Then you remove it, and over a bed of viscoelastic, you put the donor button. And the video is running. Video chalu nahi. So it's very important to suture. It's important to put the sutures pass through minimum 80 to 90% depth. Near about 90% would be appropriate. So this is a small video, edited video of the keratoplasty. It is a combined procedure. First, you put the rectus sutures, then Floringa's ring for stabilization. Because I've been planning a combined procedure, I put Floringa's ring. Make an AC entry, put a tryptan blue. Then the patient had secondary cerebral degeneration, which I'm removing now. Then you inflate the anterior chamber with the viscoelastic and then do the trephination. Make sure that it is centered as much as possible. You go to about 80% depth and then make the AC entry. And it's important to keep the scissors vertical. If you keep it oblique, there will be a large posterior ledge, which can cause a lot of astigmatism. And even inappropriate graft host, whenever healing happens, there can be some tissue there. So sometimes you'll have synechiae, which can be just cut off. You can actually swipe it with a spatula and see, but quite often it is rigid, and then you have to do this. So I'm attempting a rexus here, but I see that the anterior capsule is fibrous. So I took the vanas and I'm making a mechanical cut in the anterior capsule and making a large capsulotomy. Do a hydrodissection. A pretty large nucleus, but it has to be just rotated out. And do a Simcoe aspiration as you do in any other cataract surgery. It's not necessary because normally you have a bulging PC, so it is not necessary that you have to be perfectly complete in your aspiration. If you remove most of it, just leave the few fibers which is sticking on the PC and put the lens as much as possible in the bag. If you put it in the bag, the chance of it getting dislocated later in the process of keratoplasty would be much less. Then you put the corneal button and start the suturing. So first you put the 4 stay sutures and make sure that the graft is proper. So in case there is some incompatibility there, or you feel that one area it is not properly approximated, you have to re-put the stay sutures and then you put the fill-in sutures. Usually interrupted sutures is that what we do, and continuous suturing nowadays have gone out of vogue. The outcome of keratoplasty basically depends on 3 factors. First is the recipient pathology, probably the most important thing. The second thing is the donor quality. If you have a good quality donor, then the results are bound to be better. Then the care, both the surgical care that you give and the post-operative care. It's the most important to follow up the patient. It's not like cataract surgery, you just can't forget the patient. You have to keep the patient on a 3-monthly follow-up. And if there are any signs of rejection, like photophobia, redness, or decrease in vision, patient has to repeat immediately. So every patient would be counseled preoperatively very well that it is important to have a lifetime follow-up. Just a brief mention of therapeutic keratoplasty. Therapeutic keratoplasty is an emergency procedure. It is done in conditions where the medical treatment fails. It is only if the medical treatment fails you consider therapeutic keratoplasty. It's a totally different ball game. You'll have a lot of fibrotic membranes and all that. Even if the patient has a cataract, generally we don't do cataract surgery along with it because the risk of endophthalmitis would be more in such a case. So I'm not going into the details in the interest of time. So I would like to conclude saying that penetrating keratoplasty is very relevant even in this time when the lamellar keratoplasty is ruling the roast and where you hear mostly about lamellar keratoplasty everywhere. But in countries like India and in other developing countries, penetrating keratoplasty is still very relevant, accounting for about 80% of transplants. And if given proper care and follow-up, it is a highly successful procedure. Thank you.
Thank you, Dr. Anil. Actually, it was a very nice presentation. Now, also, there is a lot of indication for penetrating keratoplasty, and there is a lot of success also. So, you have to